Can we measure mental health with machine learning and brain imaging? If I show you this picture of a brain, what can you tell me about the mental health of the person? How old is this person? Is she at risk of developing Alzheimer's disease? Is she depressed? It's quite challenging, isn't it? So, first I'd like to talk about the hope, imaging biomarkers, then the challenge, the Achilles heel, the evidence for prediction, and finally, the vision, more ecological validity of the imaging biomarkers. So the agenda is to use machine learning to link brain images to mental phenotypes. And the first challenge is that of heterogeneity. We need to work at the population level. So will patient heterogeneity, image heterogeneity break the agenda? A few years ago, we ran an empirical study of autism biomarkers. Autism is challenging to work with because the diagnostic criteria are based on the symptoms, and it's sensitive to things such as the parent's socioeconomical status. We worked on NABIDE, which is a post-hoc aggregation of data across many cities and many countries. So, a difficult situation with much heterogeneity. And the question that we asked is, can autism biomarkers carry over to new sites? So for this, we put a bunch of sites in the training set, learned biomarkers, and then tested these on different sites, not in the training set. And what we saw was that, given enough data, the predictions to new and seen sites would work as well as the prediction to seen sites. The challenge was that this requires at least 1,000 subjects, but heterogeneity does not seem to be a roadblock. More recently, we ran a competition to assess the state of the art for autism imaging biomarkers. We gathered a rich data set which was multimodal with cortical thickness and resting state fMRI and comprised 2,000 individuals. And we launched an open competition offering €3,000 for the best prediction of autism status. We kept this competition open during 3 months. At the end of the day, what we got was a trustworthy assessment of the state of the art, the final prediction score. And the people who participated to this competition contributed predictions as high as 0.8 area under the curve, which is a pretty good prediction score. We did a post-hoc analysis of those predictive pipeline, and one thing we did was that we varied the amount of data that they could fit. And this really showed that more data would really improve the prediction by a sizable amount, and that extrapolating to having much more data could possibly bring the predictions up to an AUC of 0.9, which is a really good AUC. So, based on this, it seems that the amount of data is currently the limiting factor. We also looked at the relative importance of the different modalities, and it appeared that functional imaging, resting state, fMRI, seemed much more important than anatomical information. Now, can we trust the published biomarkers of psychiatric conditions? And I'd like to discuss how the Achilles heel of the field is the evidence for prediction. Typically, if I give you data and model, you look at how well the model fits the data. So here I fit a straight line, but I can improve model fit by fitting more complex models. And you can see that I can get an excellent model fit. Now, this is really telling us that the quality of fit on the data that has been used to fit the model is not meaningful, and that we really need new data, which we will call test data, to measure the prediction ability. Now, this is classically done, given a full data, by splitting it in a trained set and a test set, training the predictive model in the trained set and measuring the prediction accuracy on the test set. And possibly this is done many times in a cross-validation loop. Now, this is what participants were doing in our competition, but we had kept a private set hidden that we never gave them. And what you're seeing here is that a few participants obtained excellent scores on the public set, but pretty poor scores on the private set. And this was going against the incentive of the competition, because we were evaluating for the price on the private set. So what happened? If we looked at how people worked during the competition, what we can see is that at the start they had similar accuracy on the public set and the private set. And as they worked, they improved the accuracy in the public set and sometimes pushed it really high. But it didn't always improve on the private set. And so what we're seeing here is that people, humans, were overfitting by optimizing the public set score. The challenge here is that cross-validation is noisy. It's not fully trustworthy. Why is that the case? Well, because of sampling noise. We only have a finite test set. Here, I'm looking at the sampling distribution of the test error for a study size of 100 data points. And we can see that the sampling error is plus and minus 10%, which is pretty big. Now, if I increase the sample size, it goes down. But with 1,000 subjects, we're still looking at plus and minus 3%. And it gets worse if we start optimizing, because we're going to explore the tails. Now, what happens if I start changing trivial things in my prediction pipeline? Here, I'm showing the observed prediction accuracy, and we can see that it varies widely, and I'm just changing small things such as the amount of smoothing of the images. Now, the thing is, on this specific data set, the actual prediction accuracy is 50%. The data set has no information. But if I were to report the best predictive model, I would report 71%. And this is only due to sampling noise. And exploring the sampling noise randomly, then picking the one that seemingly has the best prediction. Now, does this happen in real life? Well, there is a worrying trend that the larger the data set, the smaller the reported accuracy. And this goes down as the sampling noise goes down. Now, this has convinced me that we need bigger data sets and clinically useful settings. But for this, we need to rethink the way we do our studies. And I'd like to push a vision for more ecological validity in the field. One of the challenges is the scarcity of outcomes to predict. Supervised learning really need large data sets with labels. But most individuals have no diagnosed conditions. Take UK Biobank, which is a normal aging cohort, and the largest cohort we have, with more than 400,000 individuals. And in this huge cohort. Less than 500 people have Alzheimer's disease or schizophrenia. We could be working in case control studies, but those are of limited size, and they are non-real life samples. So we need to turn to new outcomes. Let me give you an example. We could look at brain age, which gives a proxy clinical outcome. So one thing we did in the past was train with chronological age and predict the age and call this brain aging because it's the most likely age given an image of the brain. So what we did was that we predicted age as well as we could with a mean absolute error of 4.3 years. And what we saw was that the discrepancy with chronological age, which we sometimes call the brain age delta, correlates with cognitive impairment. So what we have here is a biomarker that's built from a surrogate outcome, that this outcome is not directly clinically relevant, but the biomarker itself is useful. So I'd like to push forward the agenda of proxy mental health measures. These should give us objective assessments of mental health, and they should be extracted despite the lack of reliable diagnostic information, and try to integrate complementary patient information. So, such biomarkers could be useful for treatment development, for public health policy, or for personalized medicine, and they should be applicable to a wide population beyond a specific disorder. To build them, we could use machine learning on imperfect correlates, such as brain age. Recently, we looked at whether we could systematically derive such proxy measures. And we did this to try to approximate canonical assessments, such as aging measured by age, or neuroticism, fluid intelligence, that are all measured with imperfect tests of those psychological constructs. And we looked at deriving such proxies from brain imaging, but also sociodemographics. How do we judge the usefulness of those corresponding proxy measures? Well, we looked at their ecological validity. We looked at how well those proxy measures correlate with real-life behaviors, such as the amount of alcohol consumed, the amount of exercise, the amount of sleep, cigarettes, and what we can see is that those different proxy measures built from brain imaging correlate well. Even more interesting, they correlate better than the original measures that were used as targets to build those proxy measures. So they seem to be more ecologically valid than the original measure. Now let us look at the importance of brain imaging. And if we look at age, for instance, I've shown with the filled line the quality of prediction of age with the brain imaging and with the dotted line without the brain imaging. So we can see that brain imaging helps us to measure aging. Now, if we look at the other constructs, the psychological constructs, this is no longer the case. Brain imaging is no longer helpful to predict these. And to me, this really shows that we need to integrate sociodemographics in our image analysis to capture the psychology. Now, to measure mental health from the brain, let me recap. To build reliable biomarkers, we really need large sample sizes, and we really need to worry about the quality of the evidence of generalization. And I think we should also focus on using proxy mental health measures, because these can be applied to real-world cohorts, larger data sets, and they can seek better ecological validity. Thank you.